Okay, we have one last presentation. Daniel Bausch, who is a professor at the Tulane University Health Sciences Center in their Department of Tropical Medicine, and is at present seconded to the U.S. Naval Medical Research Unit number 6 in Lima, Peru, where he heads the Virology and Emerging Infections Department, is going to talk to us about observations from Africa that may inform a research agenda. Thank you.
Thank you. Thanks for inviting me, and thanks to all of you for coming to listen. I'd love to have time to delve into the many very fascinating scientific questions that have come up, but my job here this morning is really just to give you a glimpse of how things are going in West Africa. We have had some opportunity, of course, with patients here in the United States and to take some very valuable observations, but of course we hope not to have more opportunities, and so really the research that needs to be done if we're really going to delve into this, and the virus is in a very difficult area of the world to work in West Africa. And so I'm just going to give you basically a glimpse of how this is, because most people, of course, haven't really been on site. I haven't been on site in the last 21 days, fortunately, or I probably wouldn't be here, but and so it's really giving you an idea of the challenges and just a glimpse of how things work here. So first of all, we need people, and CJ alluded to this, and this is one of our biggest challenges, the labor to do this. And we take a country like Sierra Leone, where the medical school was closed all during the war. After that, graduated about 10 medical doctors a year. Probably, I would guess, half of those are drawn off to the brain drain to begin with, and then some estimates of 20% of them have already died of Ebola. So you try to ask the question, who's going to do this work? And of course, there's a competition between the work that needs to be done and the public health response and patient care, and then the research. So we have a big problem there. We try to get around that with some issues I'll come back to that. So here, do we use the local labor? How much of that is there? Or of course we have international labor. This is a photo taken of the first training that we did down in Anniston last month, and trying to get some of the international PHS and DOD and other people trained to work in this. But of course this is a difficult task as well, to get all those people trained and over there, and the volunteers also. How many people have the time, the interest to really go and take care of patients who might look like this? These are very dangerous patients sometimes. It's hard work, it's stressful work, and so trying to do this and be in a situation, if you're a doctor in a hospital in the United States and you tell your chief of staff that, okay, I want to go and work in West Africa for a little while, difficult to begin with. They say, well, who's covering your patients while you're gone? How is that working? Your wife or your husband may not be real excited, and now of course we're adding on 21 days where you're not working after you get back. So the labor both internationally and locally is a big challenge. And so I'm going out of order a little bit here, but and then, yeah, as I mentioned, the 21 days added on is, we need to fight against that and try to inject some reason into that. And then the infrastructure. So I've been kind of, not intentionally, but found myself playing the role a little bit of a spoiler in some of the meetings like this. It's not that I'm opposed to the research or opposed to clinical trials or anything like that, but sometimes there's some unrealistic expectations of just what we have and what it might take to do this in the field. So these are the sorts of settings. This is an Ebola treatment center. The upper one is in Conakry, Guinea, the lower one in Gekidu, Guinea, in the epicenter of the outbreak. There are many other pictures, of course, and these vary a lot. So here's kind of something that you might see in the beginning of an outbreak, very rustic settings, sometimes, unfortunately, still the rustic settings that we have in West Africa, not what we want them to be, but just what we have with the capacity right now. And some of these are really much less treatment centers, but just places for someone to go, hopefully get some oral rehydration solution, some Tylenol, and a place to die out of circulation to not infect other people. So when we have this sort of setting, and then we contemplate something where we're going to do studies where we need to draw blood samples every 4 hours and have a cold chain and electrolytes and these sorts of things, it's not that they can't be done, and so I don't mean to say that this can't be set up, but I think we just need to be realistic about some of the challenges that are ahead of us. This is another photo This is a treatment center in Kenema, Sierra Leone. Of course, again, not really this one here is Kenema, Sierra Leone. This is in Conakry, Guinea. Again, not really how we would want this to be. Don't like to have all these beds together. We'd like to have separate rooms, but this is the sort of place, you may have read about it, where the nurses were going on strike frequently. We had a lot of nurses, healthcare workers who were getting sick and dying in this area. We had times when we had 70 patients with Ebola here, and myself and one other healthcare worker to try and take care of them. So when you talk about, again, trying to do research and say we need to draw blood, we need to monitor this or that, when you have this sort of setting, of course, very difficult. So we need to increase the capacity. And it can be like this. This is a much more ordered setting. This was not from this present outbreak. This is a photo from Gulu, Uganda, but this is the sort of thing what we'd like. Of course, today we wouldn't like to have those beds all together, but sometimes that's the only choice we have. A lot has been discussed about the personal protective equipment and leaving the safety issues and what's the right PPE aside. Just no matter what PPE you use, this is very cumbersome work to do in that PPE. And so if you use this as the MSF prescribed PPE that really you can stay in for about an hour and a half, really, until your core temperatures get up to potentially dangerous levels. This is closer to what would be advocated by WHO. We actually recently did a process at WHO to have new guidelines on PPE that just came out yesterday. You might be interested in looking those up. And of course, there's the Obama challenge for PPE to try to really innovate into new things beyond that. But regardless, this is not the sort of setting where you can just say, let me go in and work for 5 hours at a time and take all the blood samples that I want. It's cumbersome work. It's stressful work. There are other issues that are in place. And then also on the laboratory side, this is a mobile laboratory set up by the European Union. This was in Guinea. And so these exist in a couple different places. So CDC, European Union, Public Health Agency of Canada, various places have set up these mobile laboratories. But of course, they're mobile laboratories. They're really meant for diagnostic purposes. And right now, they have many, many samples coming in. And so not only sometimes is the capacity of the treatment centers overrun, but the capacity of the laboratory as well. So we also have the same situation where we need to think, who are the personnel who are going to be working in these laboratories, and can we dedicate them to the research, and what are their priorities between research and the just routine public health diagnostics that need to be done. Also, just an example, trying to monitor and take some of these data in the laboratory. In Guinea, we were using this iStat device. Some of you may be familiar with that. Turns out that this device doesn't really like the heat and humidity in West Africa, and so we really had a difficult time using this in most of the places. You can play with it and get it to work if you kind of put it on a bed of ice, but of course, how many beds of ice do you find readily available in these places which don't routinely have, that's not the sort of thing that's routinely there, and electricity is not a given, running water is not a given. These things all get set up, of course, by MSF as the group that's used to doing it. It can be done by other groups as well, and is being done by other groups, but it just takes a lot of energy to get this together. We've found that the Piccolo that you put on a tabletop is a little bit better for this, and not quite as sensitive to the heat and the humidity. And then data collection and transfer, of course, that's the whole point of doing research. We want to collect data, but when you're collecting data inside a ward, you have to have a way to get it outside the ward, right? And so you can't just gone are the days years ago where I used to just throw the patient charts out the window, spray them with bleach, and let the sunlight hit them for a while, and then move on. But I don't think we can do that anymore. So we have to have ways, a little bit higher tech ways, and this can be done using cell phone technology and tablets and different things and electronic transfer. So it's possible. But again, there are just many steps that we need to go through. And again, this is, you can see the gloves that this person is wearing. It's not that easy to write all this stuff down in the heat and all the other things going on. This is an example here where people are, they're giving the information on the patients. They wrote it down inside, and then they're just recounting it across the fence to other people who could write it down and then have it outside. So there are ways to do this. So, and then ethical considerations, of course, IRB approvals and hopefully rapid IRB approvals, not only in this country, but probably more challenging in the countries that we need to work in. They do have ethics committees or IRBs, but not necessarily ones that are used to really sitting and expediting these things rapidly. I think that, that's being approached these days because of what's going on. To placebo or not placebo is a huge, very contentious issue, and trying to find the right balance of really what is research that we need to do. Obviously talking about therapeutics and therapeutics and vaccines here. What's the research that we need to do to collect the information? As CJ said, clinical trials that are formally done so we come out of this with some solid data, but the expectations across West Africa, which were much more on compassionate use. We had a meeting a month and a half ago now at WHO. Dr. Laurie was there, and many representatives from West Africa in the initial stages to try to figure out how we go forward with some of the use of potential therapeutics and vaccines. And I can tell you, all the people from West Africa, I think the afternoon or evening when they got home from the meeting, probably had a call from the Minister of Health and say, well, which one did you choose, and is your suitcase full? Is it there today, or will it come tomorrow? So that they're not really thinking so much clinical trial, they're thinking, okay, where are the drugs to help people? An understandable way of thinking. And then diversion of labor from outbreak response to patient care and research are a balance that we would have to find. Lots of logistics, getting to the site. Of course, this takes a lot of vehicles, a lot of airplanes to get to remote areas. This is using bicycles that were unloaded to do surveillance. And so that's one of the things also that is not mentioned as much as kind of the operational research that we need to improve. Surveillance is another area that needs to be approached. But again, there's a strain on resources, because this vehicle's needed for the surveillance, but it's also needed really to get your research staff around and to do the different things on site. So those are challenges. And then in many of these places, the physical security. You've all read about this. There were some healthcare workers that were killed in Guinea last month. I can tell you some stories from Guinea and Sierra Leone of some tense moments. I think everybody who's been on site has a few of those stories, and especially when we have sometimes a resistant population. And one of the ideas that's frequently spread around about that resistance is that we are there. Ebola was either created or intentionally introduced for people in authority from overseas, from foreigners, to come in and do research on people. And now when we are doing research on people, how does that feed into it? And of course we want to and will do ethical research, but we have to be aware of the perception of that, and there are some issues that we've been struggling against. And then what do you do if one of your research staff gets sick? You need a backup plan. Are they going to get cared for on site? Are they going to get evacuated to the United States? There are significant cost and logistical implications to all that. We can't necessarily, send people. If you send a bunch of people into a battle zone, then here and there somebody gets shot. So you have to really be ready for that. I do think that we can do this safely. I do think that the PPE can work, but it's not the sort of thing that you can, as Jim said earlier, the Dallas hospital, it's not the sort of situation where you want to say, here's your patient with Ebola, here's the PPE, you have 2 hours of training, and now go. You have to set this up and think it through in advance. And then I mentioned the societal resistance and cultural barriers. Language barriers, first of all. Guinea's Francophone, Liberia and Sierra Leone are Anglophone, although if you get off into very rural areas, and some of your staff, depending upon their training, it's very common that people speak much more their local languages rather than even English, even though English is the national language of some of those countries. And so there are cultural and linguistic barriers to get over. So I think I did it all in 15 minutes or close to it, so thank you very much.
Thank you.